Can I invite our panelists up, please, for, thank you, our last session, before we then close with our award ceremony and a recap on the day. So I'd like to welcome Dr. Lynn Marie Trotti, Suzanne Stevens, Alyssa Cairns, and Dr. Dauvilliers, if you're welcome. If you can come up, that would be super. Okay, the only person you've not all met today is Dr. Alyssa Cairns, so I'm going to, if that's okay, Alyssa, give you the microphone to do a 1 minute little intro on yourself, because you're the only one that I haven't introed today.
Thank you so much. You can hear me? Yeah? So my name is Alyssa Cairns. I kind of bring a little bit of a different, is that good? Yeah? Flavor, I think, maybe, hopefully, to these wonderful speakers, some of whom I've worked very closely with as scientists. So I've dedicated 20 years of my professional scientific work into the investigation of the CNS hypersomnias. But it wasn't until 6 months ago that everybody knew and found out at the last Hypersomnia Foundation meeting, the reason why was because I have IH, and I've had it since I was 18. And have kind of a unique perspective on the integration of the science, but also very much patient focus and advocacy focused. So with that, that's who I am.
Thank you. Take a seat. All right, this is your chance for questions, both to our in-person audience and that applies to our online attendees as well. We do have a small team in the back there monitoring questions, so fire away. We've got 4 wonderful experts here. And I think if I can just identify who's got the microphone and who's a runner. Okay, so a couple of hands are up already. Thank you, Rebecca.
Hi, I don't know if you could hear me. I'm wondering, have there ever been any studies of what stress and trauma play into idiopathic hypersomnia? I'm just curious.
Who would like to answer that? I think Dr. Trotti's been voted to answer that.
Voted by the panel. I would say I can't off the top of my head think of any specifically looking at the questions of stress and trauma. What there has been, but my fellow panelists can correct me if I'm wrong. What there has been quite a bit more of is looking at the relationship with anxiety and with depression. Both of those seem to be quite commonly comorbid with IH. Probably in both cases, there may be kind of a chicken and egg problem, right? Where there's not necessarily one causes the other. Although sometimes it goes in that direction, it probably sometimes goes the opposite direction. It may be that there's some shared mechanisms. So I would say the big picture answer to that question is absolutely some mental health disorders and IH seem to run together pretty closely.
I would add on to that. When you say stress, you know, that encompasses a lot of potential things. And having shifted my practice to the VA, it seems like, you know, when they're deployed and so forth, when they start doing shifts and start doing overnights, you know, and they don't have a regular sleep schedule, that's stressful to your body. And, you know, even you know, when in the civilian world, if people work nights, it's stressful on the family. Like, it's just stress. It's just how your body interprets things, just as a thought, you know, any change in life. I don't know.
And I was going to add one thing to that is that from our discussions kind of off to the side, one of the things, the topics that has come up is really quite beautifully represented in the documentary, it was a Spoon Theory, where when you have this particular phenomenon, this diagnosis of IH, for example, or narcolepsy, you are allotted a certain number of spoons, right? it's very real. That is such a beautiful analogy. And you have to be quite aware of how many spoons that you are allotted in any given day. It might change day by day. But to that fact is, what degree do perhaps these stressors that may vacillate day by day kind of take away the number of spoons that you have, right, to cope? That in and of itself, like the general topic, hasn't really been like really well fleshed out, like the role of stressors into flares, let's call them flares, or an exacerbation of symptoms, or sleep inertia, cognitive kind of, sort of the brain fog, cognitive sphere. That in and of itself has not been really well, to my knowledge, fleshed out in the literature, but beautifully in the spoon, the spoon theory documentary.
Thank you. Next question, Jordan.
Hi. When it comes to the course of IH, kind of a two-part question. One, I'm curious if there's like a plateau at some point, or for some folks, is it just over time, it might just keep getting worse and keep getting worse. I know it's different for everyone, but I'm curious if there's literature on that. And then part two of that is there any part of this that you all are finding that IH is degenerative in any way?
So I think you're right that the course of IH is very individual. The different clinics around the world have sort of published on this idea that for some people the IH just spontaneously goes away. There's a small percentage of people with IH where it really just does seem to resolve, though we don't know why that is. It's not the norm, but different estimates maybe put it around 10-ish%, give or take. And so that's probably one direction that it can go. There are people that it seems to get worse and worse for a time. I think it's pretty common for there to be some good periods and bad periods, and maybe that's some of what Alyssa's getting at. Life is happening while people are living with this disease, right? And so the additive effects of the outside world and the disease might lead to some ups and downs. I think sometimes for people, medication use sort of over time varies in how, as you change medicine, symptoms might get better or worse depending on what's happening with medication. So there's fluctuations there as well. So I do think that it's hard to say, oh yes, this is something that's just going to get worse and worse, because I don't think that's true for the average person. It's more of a fluctuation typically. And I would say at this point in time, we don't really have evidence or a suggestion that IH is leading to neurodegeneration, fortunately.
There's some interesting information about the pregnancy kind of overlap, though, to this, is that there is some literature to suggest, and certainly, it's just this kind of subjective sense that we get in the community, in the research community, that there is a sort of temporary partial remission, perhaps a lessening of symptoms during the pregnancy period for females. And we know that IH is predominantly a female, kind of, as it's currently seen anyway, it's heavy toward the female gender. So it's an interesting thing. I think it does need to be studied more, because there might be something to be uncovered to help us understand the underlying mechanisms of the disease itself, because it does seem to shift, and that, let me know if you guys disagree, but I seem to see that patients that are female that are pregnant seem to have at least like a small period of, not full remission, sometimes remission, I don't want to say that, but a lessening of symptoms.
So I may add something as well. I agree that with Lynn Marie and also David, we reported that on the courses is very variable. And when we want to go into the detail, it's complex, because it's the duration of the disease, so that may depend also at the age at onset. When you explain the disease like educational program, it's also a big advance in the how to cope with and how to manage daily life. It doesn't mean that you remit, but you cope with your daily life. And after some time, it's also when you give drugs, there is some tolerance, what we so-called tachyphylaxis, so you need to increase the dose to have similar effect, and after you change the medication. So it's hard to say when there is a remission, or is it also, and if when it's getting worse sometime for a given subject, is maybe because of the drug, which is no more effective. It doesn't mean that the disease is aggravated. So it's very variable. And also the familial cases is different story, probably with age at onset is related to familial cases. But generally speaking, my experience is that after a while, but while is decades, so it's not years, it's could be 20 years, it's getting better. So after a few years, it's because of coping strategy, because you explain the disease, how to manage, how to spend time with your long sleep duration, how to deal with your long naps, etc. But after 2 decades could be, depending on, again, on the age at diagnosis, it's getting better. And probably it's because of the decrease of slow wave sleep that is physiological driven. And in pregnancy, my experience is the same as in narcolepsy. Again, you explain how to manage. Is it half time of work? It's highly depending on the time the physician take with the patient and not just drug-related effect. I think so.
Hello, esteemed panel. We do have some questions from our virtual audience. This person is wondering about diet, and do you see any connection in how diet can contribute to or relieve symptoms for patients with IH?
There's a little bit of data that high protein, low carb can improve alertness. And it seems to pan out just anecdotally in the patients that I've seen that have changed their diet for that. And I don't know if it's, if you have more carbs, it contributes to the ups and downs of the alertness during the day or so forth. But that's the one thing I've heard of is higher protein diet.
I think it's not specific to IH. It's specific to sleep, but not to IH. I do believe so.
Yeah. And there is also quite a bit of overlap amongst IH and many other, disorders, right? So certainly migraines, for example, fibromyalgia, pain disorders, Raynaud's, autonomic, phenomenon. And so for me personally, I have done all the things dietary-wise to try to test. I mean, IH people are really driven, right? We want to know what's going on. We want to know how to fix it. We want to know how to optimize the condition. And so part of that journey for me was modifying my own personal diet many times over. And certainly for me, and I think for other individuals with IH, and I think this is just good wisdom, right, is maintaining a healthy diet that is variety in nature and plant-based, or at least plant-heavy, and eliminating the types of artificial ingredients and we call them quasi-foods, right? Because those are just really not good for anybody anyway, right? So I think generally speaking, it just follows good sense, anti-inflammatory type of a diet.
Well, I think there's data of people that are just generally sleep deprived do not make good choices. And you start meaning that, you reach for carbs because it's satisfying and it might give you a little bit of a boost, and then it just kind of begets and it just keeps, it's like a cycle. So I believe, like everybody, you just have to be very intentional,
Yeah. And have healthy choices around you that are easy and like an easy, instead of a bagel, right? Pick up an apple. Something that's a simple supplant, right? So just have good, healthy choices in your reach that are easy, because we're tired, and certain things that would be to the average human not a overwhelming task. Sometimes eating is an overwhelming task cognitively. I know for myself, I'm like, oh golly, I'll perseverate for way too long, right? How do I get a nutritious meal for my family together while I am a disaster, right? Because some days are a disaster, and that's the truth. So having good, healthy choices around at all times seems to be helpful for me.
I think another piece some people have to think carefully about is for people who are on wake-promoting medications that have appetite suppression as a side effect. Sometimes people don't realize they didn't eat all day until the medicine wears off, and then they're ravenous at 8 p.m., and that's not a particularly healthy cycle either.
So many excellent points to consider. Okay, go ahead.
Two random treatments, thoughts about. First one is low-dose naltrexone. Second one is ketamine.
What's the question?
Have you explored those? I personally take low-dose naltrexone. I think it helps.
For our virtual attendees, the question is, have you explored using those with patients?
Yeah, I mean, as far as I'm aware, there's not any data on either for IH. Low-dose naltrexone is often used in conditions that have a lot of fatigue associated with them. And certainly fatigue can be a big piece of IH. And so sort of anecdotally, I've had people with two conditions, right, their IH and something else, be put on low-dose naltrexone to try to help with the other condition. I can't say I've had a big enough sample to really have a sense one way or the other of a consistent response one way or the other. In terms of ketamine was your other one, yes? So in the treatment-resistant depression literature, ketamine is used and has been well studied, both as a sort of acute intervention. You go into a clinic and you have this ketamine treatment for a series of treatments, and then also as a nasal spray that people can do as sort of a maintenance medication at home. And certainly in the context of treatment-resistant depression, ketamine has some benefits in the right person and balancing risks and harm, et cetera. One symptom that's very common in treatment-resistant depression is hypersomnia, sleepiness, but also sometimes long sleep durations and sleep inertia. And so while I'm not aware of any literature looking at hypersomnia absent depression with ketamine, certainly anecdotally I can say I've had some depressed patients with hypersomnia have their hypersomnia get better along with their depression with treatment for treatment-resistant depression. Not always. Hypersomnia can be really resistant even after depression is better, but sometimes you get a 2-for-1 benefit.
Thank you. I don't know if we've talked about the MSLT yet in this panel. We do have a virtual attendee question about the MSLT, and it seems that this person doesn't feel that measure is aligned well with people with IH, and they're wondering if there's any planning or research happening to move into any more objective testing for IH other than the MSLT.
I'll start just because I think if she started talking, we would be here all night. Because there's a lot to be said about that. But absolutely, the MSLT was developed for narcolepsy. That's how it came to be. And then we would just use it for any hypersomnia, just to document sleepiness. And absolutely, it's not the best test for IH. For example, this talk right before, whoever, I think it was yours, right?
Or David Plant.
David as well.
Ago.
Yeah.
Like, if you keep someone in a lab for whatever, 36 or 48 hours or whatever, and you just see how much they can sleep, and IH, it's crazy how much they can sleep if they're allowed to sleep. And of course, we can't do that in clinic, because insurance doesn't pay for it. You can't get reimbursed for, which is sad to say that, but that's how the business is run nowadays. You don't get reimbursed for 2 nights of sleep study or so forth. So we don't have the capability of doing that beyond research, I think, right now. And then actigraphy was mentioned. If you can, document 2 weeks of sleeping 12 hours a night, whatever it is, would be helpful. But the MSLT, when I suspect someone has IH and we do the MSLT, for various reasons, I tell them, don't feel pressure on this. That this is just a test to measure your physiologic sleepiness in the absence of any environmental stimuli. There's no right or wrong. And I reassure them that we don't treat the number, we treat the patient, and if they come in, some MSLTs are stone cold normal in IH because it takes them, a long time to get to sleep, but then if they go to sleep, they sleep for 4 hours. So it is not, it's helpful in some situations, but definitely not in all.
I wish you were my first physician that I saw when I had my first PSG MSLT, because taking the pressure off of the patient is so important. Like I said, we are driven, we want to know what's going on, and when we're like tasked with doing a test that could make it or break it for us, who wouldn't be stressed out about that? Sleeping in an arbitrary sleep environment is in and of itself bizarre, right? But add in the pressure on top of that, it just is downright arbitrary. And Mary Carskadden would, one of my mentors, she developed the MSLT. So she would be happy to tell you right here, right now, that she didn't develop the MSLT for hypersomnia. That was not the intent of the tool. So we must pivot away from it as one of the diagnostic sort of gold standards, right? It's like a bronze standard.
Well, and if insurance companies require, it's just that whole cycle where
move out of the lab, do something much more long-term to get a sense of the habitual scenario.
So if I may add something, I do agree that is if you have too much pressure for a test and you can not reach the objective of the test at the end. But the test is not good because there is at least 3 symptoms, as we discussed: long sleep time, sleepiness, and sleep inertia. And the only way MSLT may help is sleepiness. But you can have IH with little sleepiness. MSLT can be 12 minutes, even 14 minutes. If it's normal in terms of more than, 15 minutes or so, it's rare that patient will have IH. But if it's in the gray zone, you can still believe that the patient is affected with IH. The problem of being outside of some sleep center who are lucky to do some research is, so which test to be confident about the diagnosis? And is it sleep inertia measurement that may exist in other conditions, is not specific to IH, and long sleep recording? I try to explain that actigraphy may overestimate sleep with the current setting proposed by ActiWatch or whatever the name. So you need to be sure of the diagnosis. If not, the problem is heterogeneity will not be on the treatment response. It will be on the diagnosis. So I think the test is related to a symptoms. And if you have 1 or 2 among several symptoms, you can have in mind at the end, it may be the diagnosis, but it's symptoms driven and not diagnostic driven. And that's a big part of the puzzle. And I think ketamine and all of the other issue is also related to the diagnosis. And heterogeneity in the treatment response, that's key, is related to the diagnosis. And we will see that with orexin agonist tomorrow because it's really related to the dose. When you are stuck with few tools, it's very hard to predict the diagnosis at the end. So I'm happy to say that MSLT is not good, but you need to move on to another objective assessment.
Right.
And objective is also a problem because when you discuss with psychiatrists who play with, not play, it's not a good word, but who are involved to diagnose mood disorder or a stress disorder or whatsoever, there is no objective test. So if you go to neurology, we are lucky to have objective tests for most of disorder. So it depends also on which physician you.
Yeah, to your point, it's really, the MSLT tests the ability to fall asleep, quickly. It's sleepability versus like the quality of a wakefulness period. They're very different constructs. When you have IH, during our wake periods, we're awake, but really kind of, sort of, like we're kind of somewhere in between sometimes, and it varies across the day. So it's not going to be sufficiently quantified, detected, and it's on the MSLT, because the MSLT was designed de facto to assess the propensity to fall asleep under like sleep restriction or circadian misalignment. So it's just we are diagnosing something based on a test that is wildly inappropriate, and it's not that it's a bad test, it's just not designed for that, right? So to any other fellow IHers who are out there listening, don't give up though, right? So my message is, after my first PSG MSLT, I was defeated and didn't know that you should get another one, right? But the likes of Lynn Marie, has really pushed that forward to get a repeat. And so I did get a repeat study, and this was, eons ago, but it was like flagrantly, right, IH diagnostically. But I had to have the push to do that and the wherewithal to do that. So don't give up.
Hi. Could you please speak a little bit about promising results with the treatment of underlying viral infections like EBV and long COVID?
Who's going to take that?
So the pathophysiology of IH is really not known. So if you get an infection with the virus, COVID or whatsoever, it doesn't mean that is a trigger. It may be associated with. So I didn't see any good article to prove that there is a link. It doesn't mean that there is no association, but association doesn't mean causality. So you can have long COVID, mostly this is hypersomnolence, long sleep duration, excessive daytime sleepiness is often associated with post-viral infection. COVID is one, but there is no proof that is linked in terms of increased total sleep duration. Like immune-based story to react to the virus. So so far, I think there is no real strong argument to say that hypersomnia is following virus infection. I don't know.
But the longer, I'm sure you guys are the same, the longer I do this, the less I know. Like I think, just when I think I kind of know things, and then it comes down to maybe maybe it doesn't meet criteria for IH after whatever happened, but they're sleepy, and to be honest, no one else is going to treat that. I mean, like, we understand the impact of sleepiness and so forth on people's lives, and sometimes I don't know what you have, but if this makes you feel better, we'll discuss the risks and the benefits and keep on top of it, and you just have to treat the person, is all I can say about things like that.
So there may be times then that would be warranted to actually help in these kind of post-viral scenarios to actually administer a treatment, just to get them through and to reevaluate the situation later on, not just to leave the person sort of on an island by themselves.
Yeah, it's clinical judgment, but
yeah,
people meaning some physicians and providers are so hesitant to give anything to help alertness or anything to help sleep because of the climate of the concern. This has been my experience, because of the climate of the concern for whatever addiction or diversion. You just have to stay on top of that, and I don't know, I feel so badly when people do not get the treatment they need for a really bad reasoning.
Mm-hmm.
When it's a society problem.
Yeah.
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 And I mean, I do think if you look at the long COVID literature, they don't know how to treat long COVID. Long COVID's new.
Right.
But a lot of the tools they're using are things like modafinil, methylphenidate, right? These drugs that help with IH aren't specific to IH either, right? There's some symptom benefit for sleepiness that sort of doesn't tell you what the cause of the problem is. It just helps the person in front of you.
Yeah, a guy yesterday that I saw, he had he had sleep apnea, a million different things, nightmares and everything, and he's falling asleep at work, and he's using a CPAP, and I said, well, we can try this medication, and he said, does that mean I have narcolepsy? I said, no, if you give this to anybody, they're going to feel more alert. I mean, even with oxybate in the trials, I think I know that the OSA patients that were in the trials, they felt so much better. They didn't have narcolepsy, Yeah, so these are just covering a symptom. If only we had a cure, but we don't.
The problem, I think, that with this post-viral infection is if you just treat a complaint, you will have a lot of patients who fail about the treatment response, because you do not prove that there is really hypersomnia or really excessive daytime sleepiness. And if it's just a complaint, not being objectively assessed, regardless of which tools you want to use, you just treat as treatment symptoms and not as a disease that lead different symptoms. And in this way, you have a lot of, 2/3 or even more of bad efficacy and some safety issue. And after you try one drug, it could be modafinil or so, and it didn't respond well, so you change to another drug, but you forget to think that what is the diagnosis I should treat? Because when you treat with one wake-promoting agent and the patient did not respond, you often go to another one, and at the end, after 1 year, 2 years, they say, okay, but why I need to continue with this kind of drug? So sometimes it's better to spend time to really deeply assess the diagnosis that may lead to different symptoms, and you will treat the symptoms because of the diagnosis. I'm convinced on that. We record a lot of patients with complaint of hypersomnolence with the bed rest protocol, but 1/3, I may say, do not have the criteria at the end. So it's not good for the patient because they complain, and at the end, we do a lot of different assessment, and they didn't reach the threshold of the different tools we often do in routine. So the patient complain because they have no treatment at the end because they are below the threshold. So they were unhappy. They want to be diagnosed with a disease, okay. But after a while, after 6 months, 1 year, when you have a follow-up of them, they recover mostly, because you explain how to manage the different symptoms without stimulants, without drugs. You can also, but it takes time. It's educational program to how to cope with your daily life with your symptoms. But in my lab, we cannot treat the same patient if they are below or above the threshold, because if you do not care about any cutoff, any threshold, any criteria, why you should do the test? You just need to follow the complaint and to help the complaint, but you do not need to do test. So it's that need to be kept in mind. I think if you do some test, you need to believe your test. If not, do not do the test and just listen to the patient, and if you want just to help the complaint.
Well, but no test is perfect, as we know.
It's because you need to do several.
Yeah.
As we say, PSG, MSLT, but long sleep recording, actigraphy, biological tests, sometimes CSF assessment, PVT, depending on the major complaint. But if you do just PSG, MSLT, I'm pretty sure that 2/3 of IH will not be diagnosed.
Sure.
Thank you. Matthew?
Hi. There are other neurological, psychological conditions which can cause hypersomnolence. I'm thinking like depression or ADHD in some cases. I was wondering the degree to which those conditions and the hypersomnolence they cause are applicable to people with IH narcolepsy type 2. That is to say, like, do we know if it's a similar mechanism that could be making these people sleepy versus making IH people sleepy, or the degree to which the research looking at hypersomnolence in depressed people is applicable to people in IH? Does that make any sense?
Yeah, I mean, this has been looked into as far, I mean, David, probably one of the experts here in regards to kind of the overlap of psychiatry and hypersomnia or CNS hypersomnias. There's a lot, you know, we just don't know what the mechanism is and what direction it falls, because it could be very well that in individuals with with IH who inappropriately get diagnosed, you know, not for anybody's fault, but it looks a lot like it when you go to your PCP, for example, which was my personal philosophy. We need to really hone in on educating PCPs because you're going to be seeing that patient the first time. As depression, right? They're put on a SSRI or an SNRI, and oftentimes they don't respond well. Or they may respond some, but also their sleepiness can get like worse, much worse. And they get self-defeatist, right? It's a very kind of self-defeating feeling to be put on something that you think you're being treated for adequately or appropriately and continue to kind of be either the same or worse. Then potentially depression may actually follow that sort of trajectory. We don't know, it's a chicken or the egg sort of question, I think, but there are a lot of diagnostic phenotypic overlaps between many disorders and IH. I wish we had a clear answer for the, you know, kind of functional underpinnings, the biological underpinnings of IH. We're moving away from, you know, kind of the PSG, MSLT, outside of that to look at things that are happening outside of the sleep environment in their own environment, looking at ambulatory PSG to see if there are any potentially kind of features that may help disambiguate or separate out individuals that are that something within the sleep itself that may be a hallmark feature that predicts what is IH. I mean, so those are the kind of things that we're doing now in the field, generally speaking, from a diagnostic perspective, as well as these overlapping things that can muddy up the water, right?
I do agree 100%. I think depressive symptom is very frequent in IH, not being well managed because of the burden of the disease. So you can be depressed, and vice versa. You can have major depressive disorder and have hypersomnolence symptoms. And mostly you need to exclude depression when you make a good diagnosis of IH based on ICST 3TR, the item E. But if you have depressive symptoms as a consequences of being not well already diagnosed or not well managed, it's hard to. In narcolepsy type 1, you buy it, you can accept even being with major depressive disorder, but in IH you cannot. So it's not very nice. Same story for sleep restriction. For me, it's a big story. You know, you need to exclude sleep deprived insufficient sleep syndrome. But what does it mean? You know, if your biological need is 12, I said that today, if your biological need is 12 and you can sleep just 9 is huge compared to the general population, but you are sleep deprived for 3 hours. So we always say that 7 hours is, you have 7 hours, so you are not sleep deprived. No, it depends on your biological need that is hard to detect and is also variable as function of your age. So to exclude this differential diagnosis is very complex. It's just to be aware of and to manage as a whole. I think so.
One slight caveat there too is that there is some literature though that the PSG and the MSLT does show different features in individuals that have major depressive disorder. In that their sleep has, you know, is qualitatively and quantitatively defined, objectified as perhaps more fragmented, more like obviously fragmented, not even sort of at, you know, using, you know, kind of fine-tuned, you know, artificial intelligence, or, you know, we don't need that. But at the high level, major depressive disorder does seem to sort of, okay, so I'm getting the but like, there is some signal there that there is some, if it's true MDD versus true IH, which that's like, what is that? But yeah, there are some differences when we look at the PSG MSLT. So would encourage you to look into some of that literature.
But David Blum did a nice paper in the meta-analysis showing that slow wave sleep is fragmented, and if sleep efficiency is quite low in IH. It's not my experience, but it depends on the sorry? Compared
Dr. Plant
to
says
MDD?
sleep efficiency was the same for our virtual attendants.
But slow wave sleep was altered, right? Yes, exactly. Yeah. And that does seem to be a very encouraging, in my opinion, signal that since, again, we're focusing on different ways to identify, characterize, and diagnose potentially IH, because we do know the current toolbox is limited. And if we are, in the literature with David's most recent meta-analysis and even some current information that is coming out of clinical trials, is that slow wave sleep is something that appears to be abnormal in IH, whereby it is sort of diminished either in the time course or the overall amplitude of slow wave sleep being the most restorative, right? The most restorative stage of sleep that we all need. It's the ones that the babies get, the little ones when they're rag dolls and you have to throw them over your shoulder to move them across the room. Like that's like the good stuff, right? We want that. And there is a signal there that maybe slow wave sleep is indeed disrupted or abnormal. And I think that's, can be debated, but should be debated. And we need to really look at that because it will help us to, again, get to perhaps some mechanistic information.
Wow, what an incredibly smart audience we have. Give yourselves a round of applause for those amazing questions. And as it turns out, we are out of time for this session, so I'm going to throw it back up to Claire so she can wrap it up.
All right, and last thanks to Dr. Cairns, Dr. Dauvilliers, Dr. Stevens, and Dr. Trotti. Thank you very much.